The TMJ-TMD conundrum is real and has been puzzling the dental and medical professions for decades. This is the TMJ-TMD Demystified podcast with Dr. Tony Urbanek, where we'll connect the dots between TMD symptoms and the actual cause. We'll tackle common TMD misconceptions and educate you, the practitioner, about a simple, tested, and proven TMD solution that has already provided relief to thousands of patients, while helping practitioners build an additional source of income free from insurance control. Welcome to this episode of the TMJ-TMD Demystified podcast.
Hello, TMD warriors. Good day to you all. Thanks for being here and sharing a little time with me and me with you to talk about TMD Demystified. I am Tony Urbanek. Today's topic and title, very important, actually extremely important on this whole issue. It can actually rest as the most important topic of the entire issue of the solution for TMD. I say that sincerely. It's not hyperbole. The title is, What is Joint Splinting and Why is it so important when treating TMD, TMJ? What is joint splinting and why it is important in actually understanding and being able to treat TMD, TMJ successfully? All right, well, let's define joint splinting. If you are to argue with me, you must first define your terms. Voltaire. All right, so joint splinting is a euphemism used by orthopedic surgeons to describe how a joint is splinted, in other words, held motionless or attempting to hold it motionless when the joint is inflamed. This is an orthopedic term. It's a euphemism. There's a more specific term that you can make of it, a more academic, a more specific Latin name, but let's just call it joint splinting. And I learned about joint splinting, and fortunately I learned about joint splinting when I was a young oral and maxillofacial surgeon still in training for my orthopedic colleagues at Vanderbilt. And actually, because I knew about joint splinting in a general way as it applies to other joints in the body besides temporomandibular joint, it actually was the last piece of the puzzle that opened the door for a real solution for temporomandibular joint disorder and allowed a reasonable non-surgical solution to the conundrum of TMD. Everybody knows nothing works because they didn't understand the pathophysiology. The dental community, the dental profession still doesn't understand the pathophysiology of what's really going on with TMD. And once you understand the pathophysiology, which is described in short version as joint splinting, then everything else comes into view very nicely, very simply. Obviously, I'm passionate about this, and actually looking back through the retrospective scope, I just don't get why this has not been solved much earlier. There are very smart people in dentistry, in the professions, both surgical and non-surgical. But I swear, I think it's all because they all had blinders on. They just looking at their particular area of knowledge and just refuse to go outside the box to look at other areas. And literally, with the blinders on, they're in the box and they can't look outside. Unfortunately, because of my broad background in both dental degree, medical degree, academic degree in cell biology and anatomy, fellowship with the National Institute of Health, National Institute of Dental Research, National Institute of Dental and Craniofacial Research, and my own 2-year project on facial growth and development, I was able to see outside the box. Actually, I was looking outside the box. I did the investigation simply to see if I could find a solution to a problem that everyone knew there was no solution. Both the dentists and the physicians and the patients who get run around in circles for decades. And this is what we deal with in this practice, my practice here in Brentwood, Tennessee, constantly. Women with 20, 30 years being run around in circles by other practitioners, other providers doing this, that, and the other. Most of it smoke and mirrors that have no effect on it. If it does have effect, it's only temporary. All right, so let's get into the meat of this. I have discussed it before, but I'm honing down on it, focusing down on it, because it is the key. It is the thing that when you understand it, when you do understand the pathophysiology called joint splinting, then the rest of it automatically comes into view as describing what's really going on with TMD. And that is the reason it has not been solved until now, because the concept of joint splinting was not voiced. It was not enumerated. It was not brought into view of the doctors who are supposed to be treating this, because orthopedic surgeons are not going to treat TMD. Why? Because the jaw is connected to teeth, and that scared them off. And they don't want anything to do with teeth. They're happy to deal with they're happy to deal with joints. That's what they do. But when it comes to jaw joints, it's attached to teeth, and they go, not me, I'm not doing that. And so it's left to the dental profession. It's left to us. It's left not only to the general dentist and the oral surgeons, it's left to the academicians, it's left to the dental schools. And if anyone out there would like to help bring this little bit of common knowledge into the dental schools, it would make a huge difference. So here goes. I'll say, we'll talk about it once and we'll go through it maybe again for emphasis. And then I'll just let it be and discuss, the relationship with joint splinting to the rest of the treatment, which is truly, truly easy. Joint splinting is nothing more, nothing less than when a joint, this applies to all joints in the body, every joint, there are no exceptions. You were taught in dental school, this TMJ is unique, difficult, complicated. That was a big lie. It is not truthful. It just doesn't apply at all. This joint operates like any other joint in the body. It's called a gangliomo-arthrodial joint, and because it has a fancy name, everybody thinks it's complicated. No, it's not complicated. But joint splinting is very simple. When a joint, any joint, hip, knee, elbow, temporomandibular joint becomes inflamed, damaged, damage creates inflammation. If the inflammation doesn't solve the problem in a reasonable amount of time, it becomes chronic inflammation, which changes to a great degree the composition of the inflammation itself. Inflammation is a very, very complicated issue, hugely complicated. We know a lot about inflammation. We know a lot about chronic inflammation, but we don't know it all. But when a joint becomes damaged for whatever reason, and in the temporomandibular joint, there are only 3 causes of damage. I've discussed it before. I'll enumerate them now. The causes of damage to a TMJ are bruxism, punching and grinding, acute trauma of various kinds, and functional malocclusions of their various kinds. So we'll just leave it at that. I won't try to define each of those, but those are the only causes of damage to the temporomandibular joint. Once it becomes damaged, it becomes inflamed. Inflammation is nothing more than the body's attempt to heal. That is what inflammation is. Inflammation is the body's attempt to heal. When it doesn't heal, it becomes chronic inflammation, meaning it goes on way, way past the level where it's supposed to have been complete and finished healing. Now you have chronic inflammation. When a joint becomes chronically inflamed, it sends a signal, a autonomic nervous signal, sympathetic portion, to the brain, specifically the brain stem, announcing that it is inflamed. The brainstem then takes this information, modulates it, and sends a signal back down through the autonomic nervous system to the muscles that move that joint. If there's only two muscles that move the joint, then it sends signals to one or both of those muscles, maybe not simultaneously. In the case of the mandible, there are multiple muscles, bilateral muscles, that work in unison to move the jaw for chewing and speech and swallowing. And therefore, the muscles get signals to tighten, to constrict, to tighten up, constrict, so it doesn't move that joint. So in the hip, in the knee, in the elbow, the muscles that move the joints get signals to tighten up. And when they tighten up, a muscle tightens to a great degree, more than average. It will put extra stress or pull, tension on the periosteum where it is attached, and where it is attached to the periosteum, it stimulates the nociceptors within the periosteum to create pain. The nociceptors are receptors in the periosteum that actually then send the signal back to the central nervous system, which is acknowledged by the body, by us, the whole body, as the feeling of pain. So it's a back and forth motion through the sympathetic portion of the autonomic nervous system to stimulate the nociceptors, which creates the feeling of or sensation of pain. That is joint splinting. It applies to every joint in the body. There are no exceptions. Especially the temporomandibular joint is not an exception to this pathophysiologic route. That mechanism has been known and discussed and used by the orthopedic colleagues, by our orthopedic colleagues, for 50 years or more. So let's apply it to a easily understandable joint, which is not the TMJ. And I use the example of the elbow and tennis elbow. Tennis elbow is very well-known disease or problem, orthopedic problem, when the elbow is used too much, back and forth, primarily associated with tennis, because that's all tennis is. It's, on the court, when you position yourself with your legs, the rest of the motion and the rest of the work is done by the forearm to move the elbow, at which point, when there's too much repetition and force on the elbow, lateral epicondyle specifically, lateral epicondyle, that lateral epicondyle becomes inflamed. When it doesn't heal on its own, it becomes chronically inflamed, chronic inflammation. When the chronic inflammation occurs, it sends an autonomic signal, sympathetic portion, to the brainstem and announcing, I'm inflamed, I'm inflamed. The brainstem takes that signal, modulates it, and sends back down a signal, not to the lateral epicondyle, but to the muscles of the forearm, and tells the muscle of the forearm to tighten up, to constrict, and don't move the elbow anymore. It is the body's attempt, the body's natural fail-safe efforts to not only heal itself, but to limit pain. So it sends down a signal to tighten up the muscles get tight, they pull on the periosteum along the bones of the forearm up into the wrist, and the primary complaint with tennis elbow is not pain in the elbow, lateral epicondyle, it's pain throughout the forearm where the muscles are pulling inordinate amounts of pressure on the periosteum, stimulating the nociceptors. And this is called, in orthopedic jargon, joint splinting. All right, now hopefully everyone already acknowledges that this that the temporomandibular joint is not a unique joint. And when this joint becomes chronically inflamed due to trauma, bruxism, or functional malocclusions of various kinds, it sends a signal back down to the muscles that move the jaw, move the mandible, tighten up, constrict, but not always the same muscles, not all the same time. There are different circumstances, but the patients complain of pain wherever and any time those muscles are attached to the bone, and patients will complain of pain where the temporalis is, where the mylohyoid is, or excuse me, the mylohyoid, the masseter, very often confused with sinus pain, because he can even get pain throughout the midface. Wherever the muscles are attached, muscles of mastication, that is where you can get facial pain. When the chronic inflammation doesn't heal, and most often it doesn't heal because you have to swallow, you have to speak. If you are a bruxism, you're a bruxism person, you brux, you're going to continue to brux and stimulate the damage within the joint, and you will stimulate the chronic inflammation. When that occurs over a period of time, the central nervous system, the brainstem, continues to get signals from the temporomandibular joint, I'm inflamed, and then the brainstem sends signals back down, not only to the muscles of mastication, but sends signals to the entire neck to hold the whole head still. It didn't work. It wasn't enough just to hold the jaw still. Now what I want you to do is hold the whole head still, and the second most common symptom of TMD is neck and upper back and shoulder pain. That is a fact. Second most common symptom, headache being number one. Jaw pain, in my experience with literally 10,000 cases of non-surgical TMD, the third most common is facial or jaw pain of various kinds, but headache number one, neck pain number two. And then when that is not sufficient enough to decrease the chronic inflammation, holding the jaw still, or this, because you're not going to hold the jaw still, and you're not going to hold the whole head still. When that goes on long enough, signals come down, not only hold the jaw still, don't hold the whole head still, but hold the entire upper shoulder girdle still. And when that occurs, the muscles between the upper shoulder girdle and the neck, which are called scalene muscles, they get signals to get tight and squeeze. And what do they get tight and squeeze over? They get tight and squeeze the brachial plexus, which comes out of the side of the neck into the arm. And patients will complain of arm, hand, finger tingling and numbness. Why? Because of chronic inflammation in the temporomandibular joint will create arm, hand, finger tingling and numbness. And how do we know that? Because when the chronic inflammation in the joint goes away, is treated correctly, non-surgically, it allows the signals to stop coming down and saying, tighten up, tighten up, tighten up the jaw, tighten up the head, the neck, tighten up the upper shoulder girdle, and all the symptoms will diminish and go away over time if the chronic inflammation decreases, including arm, hand, finger tingling, and numbness. All right, the best way, the right way, the orthopedic surgeons use to treat tennis elbow is to put the arm in a sling for a while. To do what? Rest the elbow. Well, that is all that this device right here does. This device right here. It does nothing more, nothing less than separate the posterior teeth, where 90% of the loads on the joint occur through occlusion on the posterior dentition. 90% of the loads on the joint come from the posterior dentition. That is why you crack nuts with your back teeth, not your front teeth. And chronic inflammation, that was part of the solution, coming up with a solution, when I realized that every joint that has TMD has chronic inflammation. That was obvious after doing over 2,000 temporomandibular joint surgeries and having my pathology report come back 100% of the time, no matter what else the pathology report included. 2,000 cases, 2,000 pathology reports, 2,000 times. Line one with the pathology report was chronic inflammation. So those three items, that chronic inflammation is in 100% of patients who suffer from TMD, and the fact that 90% of the loads on the temporomandibular joint come from the posterior teeth, and now you add the pathophysiology of joint splinting originating by our colleagues in the orthopedic realm who knew about joint splinting for 70 years. The dentist didn't know about joint splinting, and that is why I'm talking to you about it now. So the best way to rest the temporomandibular joint is to unload the posterior teeth according to a protocol. You just don't do it whenever. The protocol is 24/7, separating the posterior teeth 24/7 for 2 months and nighttime only the rest of your life. And that handles 95% of patients with TMD if they will follow the protocol correctly. And then it gets into patient compliance. There are a few other nuances that have to do with vertical dimension. And vertical dimension is important. Sometimes you have to increase vertical dimension to put a little stretch on the muscles. That is not very often. And then protrusive habits. Some people have protrusive habits. It's a habit to protrude their mandible, which goes against allowing the mandible to go back to centric relation. Centric relation also being described as rest position. Rest position allows the joint to rest, which allows the chronic inflammation to go down. So if you put the patient back into centric relation and unload the joint by unloading the posterior teeth, 90% of the loads, then the chronic inflammation goes away. And according to joint splinting, pathophysiologic purpose, the symptoms diminish. It is that simple. It is that simple. So this device, you have to use it correctly. You have to know how it works. You have to monitor the patients to make sure they use it correctly. They follow the protocol. But the success rate is in the 90%, 95%, probably higher if you get total, complete cooperation from the patient, and and you can recognize. If you know the nuances but don't recognize the nuances, it's not going to do you any good. And it's very important if you catch a patient, and there are plenty of them, that once you either with or without a device in their mouth, they're going to have a protrusive habit. But the protrusive habit goes up when they have something like this in their mouth. And of course, so they have a protrusive habit, and they are literally distracting the condyle out of the glenoid fossa, which will do the opposite of decreasing chronic inflammation. It will stimulate the chronic inflammation. So the battle is all about decreasing chronic inflammation within the temporomandibular joint, using a device that unloads the joint. We call this thing the Urbanic device in protocol. If you'd like to learn more about it, which you should, you can go on the internet to www.urbanictmj.com. We'll tell you all about it if you'd like to be a network provider to use this patented device in your practice for your patients. By the way, half of the female patients in your practice, doctor, have TMD symptoms. Most of those patients think those symptoms of headache, earache, arm, hand, finger tingling, and numbness are coming from someplace else. Their ringing and fullness in the ears is coming from somewhere else. But if your hygienist has somebody in her chair that can only open 35 millimeters and she's trying to figure out how she's going to get her teeth cleaned, you can count on that patient having TMD by definition. This is a huge unsolved problem until now. Now it is just a matter of getting the word out, getting the knowledge out for my dental colleagues and hygienist colleagues to understand the pathophysiology and to recognize the problem itself, to recognize this problem. 45% of females have temporomandibular joint symptoms between ages 13 and 75. The problem is easily solved by using a protocol along with the device that separates the posterior teeth that the patient can speak with, and that is the factor. There are several things that you can make. You can make one in your own little lab, and we have doctors do it, as long as it doesn't look like that or look like the latest type of device, which we have now made CAD-CAM. Our current device is made CAD-CAM. Sorry. Now the device looks like that. As long as it doesn't look like type 1 or type 2, you can put a piece of plastic between the patient's front teeth, but they can't speak with it. You have to be able to keep it in your mouth long enough to speak with it comfortably for a great length of time. The protocol we worked out is 2 months, and if they will do it 2 months, 24/7, then you go nighttime only for the rest of the patient's life. That will decrease the chronic inflammation adequately to solve the problem. I made my point. I really enjoyed talking with you today. I hope you have gained something from this. I truly do. This problem has been solved. It's just a matter now of getting the information out to as many doctors as possible. With that being said, I look forward to next week when I'll pick out another topic. This is TMD Demystified, and I am Tony Urban.